spine surgeon here in Dallas, Texas. I do everything from the skull down to the pelvis, disc replacements, fusions. In my live sessions, I like to answer questions. I usually go over kind of 10 most common questions. Some of those include my thoughts on chiropractors, my thoughts on MD versus DO, thoughts on ortho versus neuro, how to get better from a disc herniation, how to avoid spine surgery. That's kind of my main goal. If I can get someone better without spine surgery, they're gonna send me 10 more patients than someone that you operate on. And that's just kind of how it goes, because getting people better without surgery builds a good level of trust and a good level of care, and that's really important for me. It's especially important because I am one of the few surgeons that are kind of, or not, I don't know about that. How about this? I grew up here in Dallas, so did my wife. My parents grew up here, our parents grew up here, our grandparents grew up here. So we've been in this community for a long time, and so I just want to have a very good, honest, ethical reputation. And so that's something where, I'm not going anywhere ever. I'm going to be here forever. So I just want to make sure I kind of take care of my community, take care of my parents' friends, my friends' parents, and now that we're all getting a little older, even my own friends. So with that, I'd love to kind of answer some questions. Again, I do everything from the skull to the pelvis. I do disc replacements, fusions. I'll go over what this is. I'll go over different types of disc replacements and kind of when someone should have one and when someone should not have one. Education, I went to high school here in Dallas, Cajon Park, then SMU, then Texas Tech, also known as the Harvard of Texas, and then Miami, and then Philadelphia. And after 11 years after college, you then become a full-fledged spine surgeon. So how about that? Kind of going over a couple additional questions I'm seeing here. Nice to find your content from Road for sure. Kind of on all of the platforms, YouTube and kind of whatnot. Kind of go from there. I see a couple questions here. Can you tell me what spinal stenosis is? For sure. So spinal stenosis is, you can have in the neck or you can have in the lumbar spine. Essentially, if this is your spine, bone disc, anything that causes squeezing of the nerve tunnel. Again, here's your spine. When you're walking, you look like this. Anything that squeezes all of these nerves here, so if the tunnels here, it squeezes it, creates something called spinal stenosis. Again, appreciate all the likes coming through. That kind of helps promote this to your peers who are having the same issues. The things that cause spinal stenosis could be a disc herniation that pushes back. It also could be joint arthritis, just like you get maybe a big callus formation on your foot. Big callus formation on your elbow, that's your body laying down extra tissue to protect itself. If it does that into the canal, it causes spinal stenosis. Good question from Matt. Why does my sciatic nerve keep getting inflamed down one leg and down my arm? Well, I don't know for sure, but in general, when I hear about people talking about that, the sciatic nerve is at L5S1. It could be from a disc herniation pushing out. It could be from something called anterolisthesis, where one bone slides forward on the other, and it's kind of pulling that nerve. That's a common thing I hear. Or it could be from the joint arthritis, and it's squeezing the nerve, and that's not the problem. It's just your nerve getting kind of used to it, then not used to it, and kind of going back and forth, and that kind of creates the on and off effect of the shooting down pain. You frequently can tell that either from x-rays and MRI. Someone saying, can you see all my likes? I can. I appreciate all the likes coming through. Again, that kind of helps promote this to your peers. From Whitney Myers, asking about one of my favorite medical conditions, spondylolisthesis. So that's a big medical word, really long, hard to spell sometimes, but essentially what that means is when you have your spine and one bone is slipping forward on the other. It's almost always at L4, L5 or L5S1, kind of different age groups determine who has it more, but an x-ray really just shows it, and MRI shows it also. The reason you get that is severe joint arthritis in the back, and so if your joints normally kind of lock into each other and don't move, when you get severe joint arthritis, they kind of are unstable. They're not the most coherent one. I'm trying to say it in the simplest English because I know not everyone has a very boring background of 11 years of beating down your brain with medical information, but that's when it kind of slips forward. You don't have the integrity of the joint, and that is the issue. Another way, Matthew Shimmy, if I'm pronouncing that right, says he has a pars fracture. Well, the pars fracture is another way. It's actually my more favorite way to treat these spondylolisthesis. Again, when it slips forward like this, you can either get it from joint arthritis or from a pars fracture. A pars fracture is my most common thing that I like to treat. I don't know if that was the appropriate English. Is the most thing I like to treat the most. Doesn't always need surgery. Usually kind of the recognition and the management of it non-surgically is the first steps. A couple other questions. I can't even get PAL, I don't know what that means. Pain relief from doctors or pain management. Matthew, I'd love the opportunity to take care of you. In general, not trying to have this be a marketing session for me or anything like that, but I do about 15 new patient telemedicines a week, kind of from all over. Love it from, you get x-rays back home and then an MRI. A lot of people do the visit with the MRI because they have that CD and they have x-rays at their doctor's office. Well, you need to get those x-rays. That's a key part of it. I need to see at least 4 views: a straight on view, lateral view, flexion, and extension. If it can show the hip joint, that's even better, because one of the things that I'm going to harp on a lot today are something called pelvic parameters. And for all those that are now really bored at home, what are pelvic parameters? You've heard all up before, once you get one spine surgery, you need another. Well, that's not 100% true, not 100% untrue. The reason that's less true today in 2023 is spine surgeons are smarter. We're trained better, and we know what this thing called pelvic parameters are. This didn't really exist 10 years ago. It wasn't taught. What pelvic parameters are, without getting really too boring, is if you look at the hip joint, that's not shown here, and you measure it from the S1, you measure it from the L5, you look at this thing called lordosis. Pretty much whenever we do a spine surgery, especially a fusion, we want to make sure we're creating or maintaining lordosis. If you don't, so back in the day we used cadaver bone. When we didn't do certain things in the disc space for inner bodies, we were just leaving patients either neutral or kyphotic, and that puts more stress on the other levels. Now, the younger or not just the younger generation, all spine surgeons are more educated about the importance of lordosis, keeping the curve in the spine, and so it helps decrease the rate of adjacent segment disease. From T Black saying, yes, I made a live stream. Great to see you, T Black. I'm glad you're in on this. Love your head cap. Thank you. I'm not sure where I got it from. Where do I practice? Dallas, Texas. How do I do a telemedicine? Well, I don't want this to be a marketing thing, but pretty much just direct message me, DM me on any platform, and I can send you the information. Obviously can't give medical advice, but just direct message me and I can do that from there. Again, I'm in Dallas, Texas. Best disc replacement model. There's really not a bad one, or if there is a bad one out there, I guess we don't know it yet. How about that? There's definitely been some models out there that never necessarily been recalled, but just other generations came out that replaced it. In general, for the lumbar spine, there's about 3 to 5 ones that are commonly used. In the cervical spine, it's probably about 6 different models that are commonly used. The 2 models I have here, and I'm not at all endorsing them, I'm not trying to free market or whatever the term is, but this is the Mobi-C disc replacement, and this is the Simplify disc replacement. The way these work, and these are both cervical ones. I'm a big fan of cervical ones. I'm not a diehard fan of lumbar ones, but I'm not gonna vilify someone for doing lumbar. I just don't. It's kind of a different story. Very few of my friends do lumbar disc replacements. I'll just say it that way. But the way these work are, if this separates, there's kind of this metal end plate that goes into the bone, and then you have a spacer. This is called PEEK. It's like a medical plastic. It's the same thing that they use in, it's almost the same thing they use in knee replacements, and there's another metal thing. So that kind of helps keep the motion at that area. This one from Simplify is similar, but they use a ceramic piece in the middle. Both of them are approved for 2 levels. Frequently I hear patients that comment that they need, and that's a big quote unquote, a 4-level disc replacement, and so their doctor is making them pay cash. Because it's not FDA approved to do more than 2 levels, insurance won't cover it, and so they need to pay cash. Well, you can obviously see I'm pretty darn critical about that, because I just think that's extraordinarily rare that really all 4 levels need surgery at that time. They all might not look perfect on imaging, but the best indication for a disc replacement is disc herniations, not necessarily arthritis or disc degeneration, it's disc herniations. So now you're telling me you have 4 levels of your spine that all herniated out at the same time, that 4 levels all kind of are all symptomatic at the same time. I don't know about that. And so now you're getting 4-level surgery. No, nothing necessarily wrong with 4-level surgery. If you need it, you need it. But I just hate it when people pay tens of thousands of dollars for medical insurance and then their doctor says now you have to pay cash. So that's just my thoughts. Again, maybe I'm the bad guy for not doing more disc replacements, or because I'm fusing people, so maybe time will tell. But I don't love it when people travel across seas or across the country for 4-level things that they're paying cash for. Just because you pay cash doesn't necessarily mean it's better, is something to always kind of think about. I'll kind of get to a couple of these questions here. From Romskim36, Comskid MD36. Doctor, what if you have clipple syndrome in the neck? Is fusion the only option? That's a huge debate. Clipple syndrome, for those at home that most don't know, in the cervical spine, this is a lumbar model, but in the cervical spine, it's when you have congenital fusion already of a couple of your bones. You can do off-label disc replacements, but the overwhelming majority of spine surgeons would say if you do need surgery, it should be a fusion. But it kind of just varies based on your CT, MRI, and symptoms. So it's hard for me to kind of put a blanket statement on there. But clipple is a very unique syndrome. I have 2 patients I'm actively treating now that were kind of floating around the surgery idea, but we're kind of seeing where they get. Does massage work? Yep, love doing massage. Chiropractic therapy, I support that for the lumbar spine. For the neck, I'm okay with cupping, needling, things like that, but I'm not a diehard fan of traction or popping the neck. I think that's pretty darn dangerous. A couple questions from my good friend T Black. The spine doctor I went to last week told me I have to live with the pain. I've already had it for a couple decades. I don't want to do surgery on someone my age who's 65. 65 is pretty darn young. I'm not just saying that in general. I think 65 for spine surgery is super young. So maybe because you're 65, you're Medicare, and they don't take Medicare. I don't really know what they mean by that. 65 is extraordinarily young for spine surgery. So if that's the reason they don't want to do it, maybe there's more to it. I'm not really sure what to tell you, but a high percent of my patients are well over 65. I've operated on a few 90-year-olds electively, several 80-year-olds. I'm not itching or trying to operate on a 90-year-old, my goodness, or an 80-year-old, but every now and then they need to, and we just do it at a really big hospital. And one of my things I offer patients, I use the same anesthesiologist for the most part for all of my cases. MD, not a nurse anesthetist, so he's now become one of my friends. We talk on the weekends, we talk after work, and we just have a really good system taking care of patients. I think that's a big deal. It's not necessarily the spine surgeon, it's also the treating team, the nurses, the anesthesiologist. So if a patient's old, 65 is not old at all, part of the care is not just the mechanical work I'm doing in there, it's kind of the entire process of the hospital system and the nurses. There's ICU. I think only a few times we've actually used an ICU after surgery. It just depends on what the case is. So I don't think 65 is too old. I don't think any spine surgeon, minus that one he said, thinks 65 is old. Okay, I'll get to a couple other questions. I apologize for doing that on a long one. Have you dealt with SI joint pain and AS issues? Are you ortho or surgery only? From Red. Yep, dealt with SI joint issues. I'll do SI joint fusions. I don't love SI joint fusions. I think really maybe it's like 8% of the patients that think they have it actually do have it. I think frequently patients say they have SI joint issues, they get injections, they tell me, not with me, didn't help. And then they get an SI joint fusion, not with me, and they say, oh, it didn't help my SI joint pain. Well, then you didn't have SI joint pain, it was something else. So that's kind of that thought in general. A couple questions. What is a laminectomy? From Nemo. A laminectomy is essentially something where if you're walking in, laying down on the back part of the spine, the doctor makes kind of a cut in the bone, takes off a piece, cleans out the arthritis. In general, for myself, I don't want to speak to how your doctor does it, but my rehabilitation protocol for a 1-level and sometimes 2-level laminectomy is it's an outpatient procedure. I let the patient get up and walk immediately after the surgery. That's a big part of my care. That decreases the risk of lung issues, blood clots, is getting up, walking that day. I'll let the patient start working with a home health and this physical therapy program that week they get home, a couple days after they get home. Usually by about 6 weeks post-op, I'm taking off almost all restrictions. I'm letting them go back to golf, I'm letting them go back to running, cycling. This varies if the patient's a 30-year-old, 40-year-old, or 80-year-old, but in general, it's a pretty darn quick recovery process if a patient gets a posterior lumbar laminectomy procedure. The other thing that is really important with those is, it's not a fusion procedure. The only thing I need to heal is the skin and the tissue on the back. So that's why I'm kind of very supportive of the cases I do. I think that probably, 60-70% of my cases are a laminectomy. It's just one of the most common things that not just I do, but I would assume most spine surgeons do. They're just a great procedure just because there's such a low complication risk, just because you're not really pushing the limits. You're not putting in cages. You're not having to deal with tricky anatomy. Question from E. Hi, having surgery on L2 stenosis and a disc repair and infusion. Is it possible that my emergency gallbladder surgery caused some damage to the disc? Gallbladder surgery is 4.5 hours. I don't think so. You know, your gallbladder is kind of way over here. Could that affect your disc? It could if like there was an infection and it seeded the disc, but in general, without knowing really anything about your case, it's not too likely that a gallbladder surgery injured your lumbar spine or injured your disc. What does the facet look like when manipulated? That's an interesting question from Dirk. So if this is your spine and they manipulate it, it'd be like this, like me pulling it really crazy and doing, oh my God, see, I just broke this model. So imagine if that happened to you. See, I wasn't even planning on doing that. Now I gotta go figure out how to fix this model. So that might be a live story of what happens when they manipulate your spine and trying to pop your spine and twist it. It's just doing a whole lot of nothing, and I'm not a huge fan of it. So you owe me a new spine model. I'm very sad. I like this one a lot. Again, I appreciate all the likes coming through. I appreciate all the people laughing, but that is kind of what happens when they do it. Are inversion boots a good or bad idea? I don't know what inversion boots are, but if you're talking about like an inversion table, I think inversion tables are a good idea. I'm young and pretty darn active, and I think they're very hard to use if someone's doing an inversion table. But if they're good, there's only one study on it. That's a peer-reviewed study that shows that inversion tables actually help patients avoid spine surgery. It's not in the best journal. It's not the most high-impact journal in the world, but there is definitely a science there. Another question asking about someone at Midwest Spine, any good? I'm not sure. I hope they are. I'll just kind of ask around more. I want to base it on the hospital they work for or their website. Anyone can work for a really famous hospital. Anyone can have a really good website. It really is about maybe asking patients who have been treated by them. I need iliopsoas lengthening surgery. This can cause back pain. I don't know much about iliopsoas lengthening surgery. I'm not even sure if that's a thing. If it is, let me know. I've never heard of that. How long do facet blocks work? Well, that's where you have these joints in the back, you put in some steroid and it calms it down. Make it work for a couple weeks, couple months, hopefully. Lumbaralization, it's kind of a hard topic to describe. I might just skip that question, I apologize. Pretty much it's where it looks like you have an extra bone in your lumbar spine just because at birth you didn't fuse a certain disc space in the bottom. That's the fastest way I can answer that. I know that hopefully that helped a little. Are you at home in your white coat? I am. I was actually wearing my SMU shirt, my golf shirt, but kind of right behind me is a pair of scrubs, this scrub hat and this white coat. So I don't wear these all day, but I'm not going to be, you know, if I'm going on live in an SMU golf shirt, no one's going to tune in. So this is kind of an eye grabber. So yeah, I don't normally wear this outfit. I just throw it on one so I don't have to comb my hair. Then two, that way it doesn't really matter what I'm wearing. It's kind of all about just jumping on here and getting with patients. Go Cowboys, Doc. Yep, love the Cowboys. Sadly, I wish I didn't. How long does a Medrol dose pack give you relief finishing the pack? You know, really it could give you relief for a couple weeks, and it's not necessarily that your pain comes back at a couple weeks. It's that now that a couple weeks have passed, that initial injury has started to heal itself, and so you kind of got past those few weeks of initial pain. So I love Medrol dose packs. I just called one in for one of my friends this weekend who's having some back issues, some shooting down issues. So it's a very common medication I use, but I definitely am not here to talk about the risk or benefits of doing a Medrol dose pack. You need to talk to your doctor about that because not everyone can have it. Am I in Houston? Nope, I'm in Dallas, Texas, specifically in the office. I live in Dallas. I specifically have an office in Addison and an office in kind of the Plano, Frisco area. My group is Texas Spine Consultants. We do everything from the neck down to the pelvis. It's a currently 4-person spine group. Probably gonna get a little bigger pretty fast, pretty quickly. But that spine group, it's nice being in a spine group, not on your own, because you have colleagues to bounce ideas off of. You also have people to keep you accountable. And so that's something I tell patients when they say there's only one neurosurgeon in town, it's just them, and you know, it's a group, just that one guy or girl by themselves. That's fine, you know, that's not a bad thing at all. But it is kind of nice having an accountability system. It's nice knowing that your doctor does answer to someone. It's nice knowing that if there's an issue, your doctor can always bounce treatment ideas or kind of be pushed to learn the newer things. And, you know, that's part of me living in a competitive market. There's a lot of spine surgeons here. If I do the things that I learned in fellowship and the things in training the same way, then I'm going to be replaced and outdated in just 5 years. So I'm frequently, not just me, I would hope, a lot of spine surgeons are going to courses, we're going to conferences, we're seeing what the newest technology is, because just like whatever field you're in, new things are coming out all the time, and it's not like we still go to school to do it. So you go to courses, you go to conferences, and there's little side courses, and you kind of learn new techniques. You can see new techniques. That's kind of a great way to keep your knife sharp, keep your self-focused. And the whole goal of spine surgery is doing the smallest amount of surgery through the smallest incisions for the biggest fix. And that's kind of the whole deal. Back in the day, and I still do many things this way, you make a big incision on the back, flay open the muscle, fix the issue, close it up. Well, that's fine, but minimally invasive surgery has really taken off, especially in the younger generation, because sorry, I'm trying to find some minimally invasive stuff to show y'all, because it's less tissue disruption, and that's really what hurts. It's cutting that muscle. And if there's less tissue disruption, then you can rehab faster. There's less narcotics, so it's less post-op constipation. There's less downtime, so there's less blood clots. So there's just a lot less risk with minimally invasive surgery. Question from Janet. I am bedridden for 60 days, waiting for surgery, cages and rods on L5-S1, lots of days. Well, Janet, I'm not sure if you've already seen a spine doctor. Maybe you have, maybe you haven't. 60 days, that's a heck of a long time to be bedridden. You're definitely creating some complication risk profile of being bedridden that whole time. So if you have x-rays and an MRI, I'd love the opportunity to help you. But if you've already waited 60 days, maybe you already have someone, and that should be a great way to do it. I'd love the opportunity. Another couple questions. Do you have pain behind the shoulder blades and the neck? Oh, sorry, you do. Okay. Yeah, I'm not sure what that's from. Could be from disc issues, not sure. Just reading some other questions here, trying to get some questions. I had a surgery. Okay, I have spinal stenosis and major spinal reconstruction surgery from Devin. Love to hear more about that. That's good to hear. Thanks so much for sharing. What about a syrinx in the spinal cord? So a syrinx in the spinal cord is a question from Darby, Queen of the Midwest. That's a heck of a name. Essentially is, if it's in the spinal cord, your spinal cord is actually in the brain. It goes all the way down to about the lower rib cage. But it's where, if the spinal cord, you're looking down here, it's where you have this fluid inside the spinal cord, almost like a cyst. In general, they're stable. You don't need surgery. That's not always the case. Most of the time, you need a serial, like 1 or 2 or 3 MRIs just to check on it and see if it's growing in size. And if it's stable and you're doing fine, then that's the treatment there. But it really just kind of varies. But in general, my goal today is kind of just help on the diagnosis, not necessarily help on the management, because the management really varies by patient. All right, I appreciate all the likes coming through. If we can get to 10,000 likes, that'd be really great to kind of help promote this to your peers. If everyone hit the like, I'll kind of go from there, and I'll try to answer a couple more questions on there and kind of go from there. So gabapentin, what are my thoughts? I like gabapentin. Definitely has some side effects, but it's one of those medications that I frequently get patients on, and it helps avoid or delay surgery while maybe other things are going on. So I do support gabapentin, but it's not without its own things, and I'm not there. Will the cyst come back? I'm not sure where the question was from. I'm fused from T3 to the pelvis, struggling with torn thoracic muscles. Man, T3 to the pelvis, that's one of the biggest spine surgeries we do. I'm so sorry to hear that. That's really unfortunate. I do have several patients I've had to do that to also, and it's just big surgery. T3 is up here. I guess specifically, if I count it, it's probably this one here. T3, all the way down to the pelvis. It's one of the biggest surgeries we do. It's definitely a life-changing surgery. You definitely won't ever get back to your pre-issues, but a lot of times, if you needed that surgery, hopefully it's a life-changing in a good way too, because the reason you need such a big surgery is severe adult deformity. If you have something called severe adult deformity, and this is people with a big curve, or more importantly, if you're walking this way, so if here's your side, you're collapsed forward. If you have something called sagittal imbalance, or pelvic parameters are off, and you're collapsed forward, and you have a flat back, your quality of life on certain scales are the same poor quality of life as those that have metastatic cancer and HIV and uncontrolled hepatitis C. So it's that big of a deal. We put so much of our government time, money, and focus appropriately on HIV, Hep C, cancer, but the quality of life from adult degenerative disease, where it's hunched forward, multiple spine studies show your quality of life is as worse as those patients. And there's many people here in this chat saying, yeah, that's me, my quality of life is awful. And look, you're not alone. The surgery to fix that are usually, unfortunately, big surgeries, and that's what we're trying to get better. as spine surgeons have identified big complication surgeries. And definitely those rates have come down over the last couple decades, and that's why we do things minimally invasively, and that's why we really train on deformity surgery these days. Let me get a couple more questions, and then I do got to run. I don't always love to do this all Saturday afternoon. I have 2 kiddos at home, and they're sleeping right now, so I sometimes jump on here while they're sleeping, and then when we wake up, I try to put my phone away for the rest of the day when I can. A couple more questions I'll get to. What's like life with a complete spinal fusion from Dave? Well, Dave, I don't know if complete spinal fusion's a term I would use, but how about this? The overwhelming majority of the fusions I do and other spine surgeons do are either 1 level or 2 levels. And what I mean by that, it's usually L5S1 or L4L5. Fusing just those 2 levels, your quality of life is still going to be pretty darn good. Again, this varies patient to patient, but if you could touch your toes before, you can touch your toes after. If you like to motorcycle, parachute, rock climb, after a spinal fusion, 1 or 2 levels, you can still definitely do those things. Patients ask me all the time, can I run after spine surgery? Well, the answer is almost always definitely. It depends what your spine surgery was. If you had a lumbar fusion, once it's all healed up, for sure you can go back to running. If you had something like a microdiscectomy or a laminectomy, something even less invasive, I let patients go back to running 6 weeks later. It's a pretty darn fast recovery depending on what your surgery is. So it really just varies. In terms of will your life be different? Well, hopefully it's not. Hopefully it's better in a good way. And it just kind of depends on what your surgery is. There's so many different types of surgeries. You have neck fusions, neck replacements, foraminotomies, lumbar fusions, corpectomies, taking the cage out, lateral surgery. So it's an obvious thing for me to say, not all spine surgeries are the same, not all spine surgeons are the same, and your recovery hopefully can be different based on the one pathology you have and also the thing you need to fix it. So it really kind of just varies. All right, I'm going to go over a couple other things. I see a lot of questions here, so I'm trying to get to them, but with about 1,000 people in the chat that kind of pop away. Again, I appreciate all the likes coming through. That helps. Just kind of reset the scene one more time. I'm a spine surgeon here in Dallas, Texas. Grew up here in Dallas. My parents grew up here in Dallas. My parents did. So, it's a community near and dear to my heart. My reputation is important, both ethically and on outcomes. So I take everything pretty darn seriously. I'm not going anywhere. I can't do a bad job and move. Not that others can, but that's just something to put out there. I'm going to be here forever. I do everything from the skull down to the pelvis. My emphasis is on cervical disc replacements, robotic surgery, minimally invasive surgery. I love doing laminectomies. I love avoiding spine surgery. And I tell patients all the time that come to me even for a second opinion. I'm like, look, if you come to me for a second opinion and I offer you no surgery and surgery, if you pick the no surgery option, we try to get this better without surgery, I still want to be the quarterback. I still want to be the one managing the care. It's not always great when the pain management doctor is the quarterback of the care, because you're going to maybe get more injections than you need. You're maybe going to go to the pain doc to the spine surgeon that they send you to, as opposed to you picking your own. They might send you to the pain doctor might send you to the spine surgeon that they have a relationship with, or that they just kind of send each other patients. That doesn't necessarily mean he or she is the best spine doctor even in the area. So that's why, as a spine surgeon, I'm biased in this obviously, but I like to be the quarterback of the care. I like to send you to the pain management doctor, and I use about 10, 15 different pain management doctors, honestly. We have one in our group. She's fantastic. I don't send everyone to her. I kind of try to keep you close to your area and people that I think are ethical do it. That's a little bit of a different story. That I'm from my woman, I am pretty quick and I miss them, and I apologize when I miss them. A couple other things. I'm in Oklahoma and I need a second opinion from Gordo. Well, I'm in Dallas, so come hang out with me. From Loop Navigation. Yeah, I didn't use a lot of navigation in training at heavy navigation center, but then I kind of just woke up one day and said I'm going to start using navigation, and now I can't go back. So I love using navigation for my screws. Your spine surgeon is definitely not wrong to not use navigation, but for me, I think it's just easier. It's a faster workflow, and it's just less radiation for the staff, for the doctor. And I'm working so hard, I don't want to be taken out by a blood cancer from all the radiation we have to use in spine surgery every case. So using navigation, for those at home that don't know what navigation is, it's pretty much the back or neck, and then your screws. So I don't know where all my pedicle screws are. I think I have two boys, so they take things and play with them like a pedicle screw. But then you use your patient CT navigation, almost like a video game. It shows on the screen where that screw is in relationship to the patient's bone, and that's kind of how you can direct things through that small surgery, and that's just shooting a lot of x-rays. And that's fine, that's how we've been doing it for a long, but there's just a lot of radiation. So I like using navigation because it definitely shows increased rates of accuracy. Definitely should use navigation if I could use double negative. All right, for that, I'm just going to answer a couple other questions, and I do have to go. One question from Mr. Warris is, your email, doc, is the following. Well, it's a long one, so usually I say just direct message me. I'll tell you in a second, but just direct message me, and I can send you a template. For the telemedicines, the most important thing that patients infrequently bring is their CD of their x-ray. I need your x-ray, and also I need your MRI. X-ray and MRI. If you have a CVS in town, you can bring those to CVS actually and upload them to me. If you're wondering how to do that, you can search my name at the CVS and it uploads it. You can also, if you have a CD drive at home, you can upload your CDs from home and send it to me. So I don't have a CD drive at home anymore. I have a laptop with no CD player. So if I needed to do it, I'd go to a CVS. I do telemedicine from all over. I think the furthest patient I've ever operated on was in New Zealand. That was very flattering. I've had several patients from Africa, but none of them have made it to the finish line of surgery. But kind of all over. The Caribbean, very common. I get a lot of patients from Florida because that's where I used to practice, or I used to do training there. I guess I say practice training. But I do from the skull to the pelvis with that. And I appreciate the gifts coming in. You don't need to send me gifts. I do fine without gifts, and just save those gifts for people in Africa dancing on TikTok for making a living. I think that's a pretty good thing. Some of the questions I'm seeing here, and then I do have to run thoracic outlet syndrome. Is that something you deal with? No, that's usually a shoulder doctor or an upper extremity doctor. Hi doctor, my neurosurgeon suggested to have C4 to T1 operated on. I'm scared to do it, from LC. Not sure, it's a big surgery. I don't know what to tell you. That could be a surgery that benefits you. It's just hard to say, but it's a big surgery. Another question, where are you from? I'm from Dallas, and I live in Dallas. So again, this is my community I grew up in. This is the community that my parents grew up in, so I take it pretty darn seriously. Do you do disc replacements at L4? Not really. One of my good friends does, and so if it's someone that I think really, which is like that narrow, could benefit from a lumbar disc replacement, I'll send it to him. In general, I get a lot of patients that see me for second opinions for fusions, and I tell them, I was like, you know what, I actually do support that recommendation